We will learn about tibiofemoral alignment and weight-bearing forces. There are few parameters we have to know to understand alignment of different structures, starting with anatomical or longitudinal axis. It is a line passing through the midpoint of diaphysis and parallel to medullary cavity. It helps us to understand the natural orientation of the bone in the body. This is the left lower limb, the femur in orange, the tibia in purple. This is the vertical reference. Anatomical axis of tibia is almost vertical, while that of femur is angled. It is about 5 degrees off the vertical. There is an angle formed medially by the anatomical axis of the bones, that is about 180 to 185 degrees. This is known as physiological valgus at knee joint. If the medial tibiofemoral angle is greater than 185 degrees, it is called genovalgum or knock knees. If the medial tibiofemoral angle is 175 degree or less, it is called genovarum or bow legs. Next is mechanical axis or weight-bearing axis. It is a straight line connecting the joint center points of proximal and distal joints. Let's visualize it. Again, this is the left leg, the femur in orange, the tibia in purple. This is the mechanical axis of the lower limb. It extends from the center of the hip joint between the intercondylar tubercles of tibia and to the middle of the ankle joint. In bilateral stance, that is, standing on two legs, the mechanical axis is in such a way that the weight beared by the medial and the lateral compartment of knee is almost equal. In unilateral stance, that is, standing on one leg, the mechanical axis is shifted medially so that the medial knee compartment bears more weight than the lateral compartment. This is the weight beared and this is the equal and opposite ground reaction force. We see that the medial compartment is compressed. On the lateral side, the knee compartment undergoes tensile stresses. Here is the summary of what we learned. Note the shift in axis during valgus and varus. Now we will learn about menisci. These are accessory joint structures made by the lateral and the medial menisci. They convert tibial convexities into concavities. They act as shock absorbers, reduce friction between tibia and femur, and are involved in distribution of weight-bearing forces. These are fibrocartilaginous discs. The medial meniscus is C-shaped and the lateral meniscus is 4x5 of a circle. They lie on top of tibia and are open towards the intercondylar tubercles. The meniscus is thick at the periphery and thin at the center. The lateral meniscus covers greater area of lateral tibial surface, while the medial meniscus covers lesser area of medial tibial surface. These tibial surfaces are tibial condyles. The medial tibial condyle is more prone to injury because it gets more loading, and the medial meniscus covers less surface area. Now we'll learn about meniscal attachment. The medial meniscus has greater restraints than the lateral meniscus, due to which its motion is limited and there are more chances of injury. The anterior and posterior ends of the meniscus are called horns. They attach firmly to the tibia below. These are the two menisci. This is the anterior side and this is the posterior side. Anteriorly, the two menisci are attached to each other by transverse ligament. At the periphery, the menisci are attached to the tibia by coronary ligament. This is the patella and the menisci are attached to it by patellomeniscal ligament. This is the joint capsule. Guess the name of the meniscus. The medial meniscus is attached to the joint capsule by medial collateral ligament. The anterior horn is attached to the anterior cruciate ligament. The posterior horn is attached to posterior cruciate ligament. On the posterior side, semimembranosus muscle connects to medial meniscus. Moving on to the lateral meniscus, the anterior horn connects to the anterior cruciate ligament. Posteriorly, the lateral meniscus is attached to posterior cruciate ligament. Also, it connects to the medial femoral condyle by meniscofemoral ligaments. The tendon of popliteus muscle attaches to the lateral meniscus. Here is an image for clarity. These strong attachments prevent the meniscus from being squeezed out during compression. The meniscus play an important role by increasing surface area between the two bones. Now we'll see meniscal nutrition. During the early years, the blood vessels are present throughout the meniscus. Once the weight bearing is initiated, the vascularity is lost and only the outer 25 to 33% is vascularized. The supply is from joint capsule and synovial membrane. After 50 years of age, only the periphery is vascularized. The central portion depends on the diffusion of synovial fluid. It happens by loading of the meniscus either by weight bearing or by muscular contraction. Due to this, prolonged immobilization can cut off supply to the central portion. And the avascular nature of the central portion makes it difficult to heal after injury. Only the peripheral part can undergo remodeling or repair after injury. Now about innervation, the horns and the periphery have nerve endings and mechanoreceptors. Therefore, pain can be felt by patients after meniscal tear, at least at the periphery.